Welcome to a discussion about epilepsy. In this session, we'll describe the major categories of seizures, describe the importance of awareness, that is consciousness, in the differential diagnosis of epilepsy, describe the relationship between cerebral localization of function in the brain and the manifestations of an epileptic seizure, such as NEURO, the Jacksonian march, and Todd's paralysis. We'll also describe the anatomical basis of secondarily generalized seizures and differentiate those from primary generalized seizures. We'll describe the activity of neurons and of the EEG during an epileptic seizure and in the periods between seizures. And we'll also describe the metabolic indices of an epileptic seizure. Words we'll be looking for are epilepsy, seizure, convulsion, absence, aura, paroxysmal depolarization shift, Jacksonian march, Todd's paralysis, ictus, interictal, postictal, and status epilepticus. In this outline, we'll include some definitions, some seizure classification, look at the etiology of epilepsy, the epidemiology for epilepsy, the pathophysiology, as well as the diagnosis and treatment approaches. Definitions that we'll be focusing on are seizure, which is an abnormal, excessive, synchronous discharge of cortical neurons. It literally is an electrical storm that results in an alteration of cerebral function. Epilepsy is a chronic, recurrent occurrence of unprovoked seizures. The diagnosis of epilepsy is based on the occurrence of 2 or more unprovoked seizures in the appropriate setting. A seizure disorder is the same as epilepsy. But an epileptic syndrome may include a particular type of epilepsy plus a cluster of signs and symptoms, such as the age of an individual, the prognosis for that kind of epilepsy, response to medication. For instance, childhood absence epilepsy is one that occurs in children. It has a relatively good prognosis. It responds well to medication and has certain genetic predispositions. Ictal activity, an ictus is a seizure, is the clinical, that is the behavioral or electrographic EEG activity during a seizure. Interictal activity is all of that EEG activity between seizures or behavior that might be seen between seizures that might be a little bit different from other behavior. And then postictal period is the period immediately after a seizure, and maybe seconds, minutes, or even a couple of hours after a seizure. We'll be looking at each of those periods of time. A seizure is actually a symptom. It is not a disease in and of itself. It is a paroxysmal, that is a very sudden attack of brain dysfunction. It comes on literally in seconds. It involves abnormal, high-frequency, synchronous neuronal discharge in the brain. It is a brain disease, not spinal cord. And while it may involve the brainstem, it's primarily a cerebral disorder. It can be confined to very elementary features, that is simple sensory or motor phenomenon, or may involve very complex impairment, such as altered thinking. Other kinds of behavior may progress on to a generalized seizure that's much more than just an elementary feature. It may be associated with alteration or loss of consciousness, and we'll differentiate between those two. All convulsions, that is major motor movements, are seizures, but not all seizures are convulsions. There might be seizures that in fact involve little or no movement. A convulsion is an involuntary contraction of skeletal muscles. Also note that not all seizures are due to epilepsy. Remember, epilepsy is the spontaneous recurrence of unprovoked seizures, whereas there are a variety of ways of provoking seizures. If you take enough alcohol, you'll produce seizures quite often. Certain drugs will produce seizures. Hypoglycemia can produce seizures. Electric shock, as seen in electroconvulsive shock. The brain has the ability to sustain seizures by a variety of things that upset its normal balance of excitation and inhibition. Anoxia can produce seizures, and head trauma. Those might be acute seizures and disappear as soon as the provoking feature leaves. In the pre-ictal phase, before seizures occur, some people have no warning at all that a seizure is coming on. There are others that have some kind of a symptom beforehand. We refer to that as an aura. It provides, or a breeze. It provides a warning. It may include an epigastric sensation, something in your gut just doesn't feel right. A headache, lightheadedness, or feeling depressed. It may even be poorly defined by an individual. And it may precede the seizure by seconds, hours, and sometimes even longer periods of time. The ictal phase, the seizure itself, actually lasts a relatively short time, seconds to minutes, and seizures stop by themselves, except in status epilepticus. That's when a status, that is a seizure, goes on, and that's the status that is sustained. That is very serious and life-threatening. It's uncommon, but needs to be recognized. If it lasts more than 5 minutes, you need to be suspicious and care for that patient immediately. Provide medical attention. The post-ictal phase, immediately following a seizure, may last minutes to hours after the seizure, and might include a variety of symptoms, sleepiness and general fatigue, perhaps confusion and disorientation, some agitation, any mix of these, aggressiveness or forgetfulness, that is memory loss for a while, or headache. The aggression is usually out of confusion rather than a true usual aggressiveness that we think about. And then another feature of post-ictal period is Todd's paralysis, where there may be impaired motor function in the affected part of the body. That is, if you had moved your right arm during the seizure, there would be repetitive movement of your right arm. There might be weakness of the right arm, due either to inhibition or exhaustion of that affected brain tissue responsible for that behavior. Seizure classifications are broken up into two major types: partial or focal seizures and generalized seizures. Partial seizures, simple partial seizures, that is, partial seizures are made up of two different types: simple partial seizures and complex partial seizures. The simple partial seizures, as those that you would see a simple movement, motor function, a movement of an arm, or a simple sensory function where there is a flashing light. Or it may be some autonomic alteration. Generalized seizures come in a variety of different forms. The most common is a tonic-clonic seizure, but there are also myoclonic seizures, tonic seizures, atonic seizures, clonic seizures, and absent seizures. All of these are types of generalized seizures. A partial seizure that starts out in one part of the brain, if it continues, may spread to other parts of the brain and eventually become secondarily generalized so that it looks like a generalized seizure at the end, if it spreads to both hemispheres. We'll see examples of that. We'll look at various aspects of partial seizures first. In a simple partial seizure, a focal seizure, the anatomical substrate is neocortex. Some portion of the cortex has become hyperactive. And awareness during that time is maintained. The person is fully aware of the seizure that's ongoing. And the localizing signs or symptoms depend on the cortical region. If it's sensory or motor or higher functions, for instance, we'll see alterations. For instance, if it's sensory, we might see an alteration in vision or hearing. Or if it's motor, we may see a focal clonic activity, that is moving of a hand or an arm or a leg back and forth. Or a language disruption where a person can't speak or can't understand. It could be literally, just as with a stroke that could affect a small part of the brain, a seizure could affect a small part of the brain, and instead of producing a simple loss of function as happens in a stroke, there might be some distortion of the activity of that tissue, such as a sensory phenomenon or a motor phenomenon. Simple partial seizures that involve the motor strip produce motor symptoms, and they're dependent on the anatomical localization. For instance, in the precentral gyrus, we might expect a focal activation. It could be in the face or the hand or in the leg area. If it's focal, it might just be in the face. But if it spreads across the motor cortex from the face to the hand to the leg, we would call that a Jacksonian march, and that would be a spread, but it would still be a simple partial seizure with spread called the Jacksonian march. If it moves from the into the frontal eye fields and then it reaches the neck, it may involve turning the head to the opposite side and the eyes to the opposite side. They're usually brief, but occasionally in the motor cortex you will see ongoing continuous seizure in a focal area, and that's defined as epilepsia partialis continua. It's a steady activation of a focal part of the nervous system. In particular, it's seen in the motor cortex. In the sensory cortex, there might be an aura, a sensation, most commonly seen in the somatosensory cortex, and the symptoms, again, and the signs depend on the location. It may be a paresthesia, an unusual sensation or disturbance of sensation. Could be in the arm, the leg, or the face, or other parts of the body. There may also be special sensory symptoms in special senses, and that is a visual image, seeing something that's not there, or an auditory sensation, hearing something that's not there, or a gustatory sensation, symptom where you have a taste, or dizziness. Some of the manifestations of partial seizures or focal seizures are represented in this map over the hemisphere, and we can see that in the motor strip you might have activation either of the leg area or the arm area, the hand area, the lips, mouth. Any small area that was activated during a seizure could produce movement of that part of the body. If it was in the sensory cortex, in a similar way, it could produce selective movement of the arm, the leg, the hand, the lips, the tongue, or the mouth. If we're in the parietal cortex, further back, we might see a distortion of body image. If it were in primary visual cortex, you might see a simple visual stimulus in the contralateral visual field. If it were in the parietal occipital area, you might see the eyes move to the opposite visual field, looking to the opposite visual field, because this parietal occipital region projects into the frontal eye fields and drives the eyes to the other side. If the disturbance of electrical activity was in the epileptic discharge was in the occipital temporal area, you might see macropsia, where whatever person was looking at started to look bigger, or micropsia, where things look smaller, or some other formed image that was a visual hallucination. As you come over to the auditory association cortex, you might see auditory hallucinations. As you come up to the primary auditory cortex, you might hear elementary sounds, very simple sounds. As you come up to the temporal lobe, the anterior temporal lobe, you may see a variety of automatisms, picking at clothing or lip smacking and similar. If you come into the insular, you might see vertigo, you might see an elementary sensation. If you're in a language cortex, if the epileptic activity is language cortex, you don't get speech in general, you get arrest of speech, whether it's in Wernicke's area or Broca's area. If you have abnormality, epileptic discharge that starts out in the frontal cortex and moves from premotor cortex into the frontal eye fields, then you'll have conscious movement of the head and eyes to the opposite field. If, on the other hand, the epileptic discharge started in the prefrontal cortex, you might have a forced thinking, a thought that you can't obliterate, and then have a sudden loss of consciousness. It's very common that you'll have a loss of consciousness from seizures occurring in the frontal lobe. And then if that spreads, may spread to the frontal eye fields and head area and neck area, to the point where you'll have controversion to the other side, head and eye. But in this case, it will start out unconscious because you've activated regions that connect to both hemispheres from the frontal lobe very quickly and change consciousness. You may also have auditory hallucinations from uncus activation or tonic postural movements from premotor cortex. So all of those are different localizing signs in epilepsy, could start in any one of those locations. Partial seizures also may be complex partial seizures or dyscognitive seizures. In this case, the anatomical substrate, rather than being superficial cortex, tends to be limbic cortex, hippocampus, amygdala, orbital frontal cortex, or cingulate gyrus. The core symptom is an alteration of consciousness. Not necessarily totally unconscious. The person is aware of some things in the environment, but they don't seem to be attentive to others. We can actually define it and evaluate that in many patients as an alteration of consciousness. They're not fully aware of what's going on around them, but they clearly indicate some level of awareness. Other symptoms include various automatisms, motor activity, their involuntary movements. They seem purposeless. They're arranging the sheets or their clothing. They're licking their lips, lip smacking, chewing, very common, fidgeting with their fingers or picking at their clothes. There commonly is an amnesia associated with hippocampal involvement. Autonomic and visceral sensations are very common. Fear, if the amygdala is involved. Unusual smells from the olfactory system due to activation of the uncus or the amygdala, and then taste sensations if the insula is active. As we indicated, a partial seizure may start at one location and then spread anatomically to connected sites. That's how seizures spread from one area to another. So if a Jacksonian march or Jacksonian seizure starts out in motor cortex and could move from the mouth to the hand, to the leg, and you gradually see clonic movements starting in the mouth, going up to the hand and onto the leg. And the behavioral manifestations simply reflect the areas of cortex successively engaged. Todd's paralysis is the effect of having a seizure where there's very strong metabolic activity, and following that, there might be a postictal loss of function reflecting the very same site that had been most active. So a clonic seizure in an arm may be followed by a postictal post-seizure weakness of the arm lasting minutes or even hours. Similar postictal behavior deficits may be seen from any site. Activation of language cortex may result in a lack of ability to speak or understand for an extended period of time. A seizure arising in the visual cortex might produce initially some visual flashing, and then postictally a loss of visual recognition in that part of the visual world. We'll move on to generalized seizures and recognize that primary generalized seizures, the physiological substrate is now bilateral cortex as opposed to a focal discharge somewhere in the cortex. It's bilateral cortex, commonly involves the thalamus, and a core symptom is a loss of consciousness and that it's bilateral from the very beginning. There are many forms of those. The most common form of generalized seizure is the tonic-clonic, what used to be called grand mal seizure, and you'll hear people refer to that. It's a sudden, symmetrical, major motor seizure. If you've seen movies, it's what is depicted most commonly because it is so recognizable. it's a convulsion. There's muscle spasms with a loss of consciousness, and it often lasts a few minutes. There's a tonic phase where the arms and legs are extended and very stiff. A person might fall to the ground, the jaw is tightened, there may be tongue biting, there may be an epileptic cry as the respiratory muscles are contracted and the oropharynx is contracted so that air is squeezed out of the voice box, resulting in the epileptic cry. There may be bladder or bowel incontinence. There may be pupillary dilatation. Because of the contraction of respiratory muscles that is sustained during this tonic phase, there may be apnea, that is a lack of breathing, and a person may become blue or pale or dusky appearance. This period usually lasts a minute or so. And then there's a clonic phase, a gradual transition where inhibitory neurons become activated, they interrupt the clonic phase, and there's violent rhythmic contraction and relaxation of muscles back and forth. The face may contort, the eyes roll up, there's salivation, frothing, sweating, and tachycardia quite often. Atonic seizures, fortunately, are less common. They're more common in children. It's an abrupt loss of postural tone that lasts 1 to 2 seconds. There is a risk because of falling of injury. Myoclonic are very brief, sudden jerks. Usually it could be lateralized or it could be on both sides at the same time. It could be in the arms or the legs. There it could be isolated or repetitive, very rapid jerks. They tend to be seen more in adolescents and adults, adolescents and infants, and they're often seen just before going to sleep or on awakening. Often the individual is not aware of those jerks because there's such brief and they're not, they don't reach consciousness. Clonic seizures are motoric spasms with periods of rigidity and relaxation. They tend to be symmetrical and are usually bilateral. Tonic seizures are this general stiffening that is a tonic contraction, often with the arms flexed and the legs extended, and the head and eyes may be off to one side. An absence seizure is a rather distinct one, a type of seizure, and they used to be referred to as petit mal. There is a very brief loss of consciousness with an arrest of behavior. The person may not even be recognizable, they're just still. The eyes may stare, they may turn upward briefly, there may be blinking of the eyelids, and they usually last a short period of time, just a few seconds to 30 seconds. They're much more common in children. There is a genetic predisposition to these. There may be mild automatisms or mild clonic movements, but they're not necessary. And an individual may have many of these in a day that are very brief, 10 to 100 in a day. And usually in between, the person appears perfectly normal. Secondary generalized seizures are those that start out as a partial seizure, whether it's simple or complex, and they start in one location in the brain, and then they gradually spread to both hemispheres and become secondarily generalized, involving both hemispheres, and at that point they may be indistinguishable from a primary generalized seizure. So if you come in late in a partial seizure that is generalized, you will not be able to differentiate that from a primary generalized seizure. They're much more common for frontal lobe seizures than any other type of partial seizure. Primary and secondary generalized seizure share the features of being bilateral and having a loss of consciousness as a manifestation. They also result at this point in a loss of memory during that time. It's a transient loss of memory. Status epilepticus is an emergency. The definition is that it's a seizure lasting more than 5 minutes, or that there are 2 or more seizures that don't have the individual return to their baseline functioning. They're most commonly associated, as seen in patients people who have epilepsy, and they've discontinued their medications abruptly. The nervous system had adjusted to the level of medication they were taking, and removing the medication releases excitatory drive. But they could also be triggered by alcohol intake, by certain sedatives, or by a fever. two different types are those that are clinical, where you would see the behavior that's very obvious, whether it's a tonic-clonic seizure, or a different type that's subclinical, and that is that there's no obvious behavioral manifestation, and you need the EEG to identify that ongoing status epilepticus. It is serious. There's a 20% mortality of those individuals who have status epilepticus due to cardiopulmonary failure, hypothermia, rhabdomyolysis, and neuronal ischemia and infarction, cerebral edema that might lead to herniation. This must be treated urgently, and IV anti-epileptic drugs can stop seizures in status epilepticus in general. The etiology of seizures and epilepsy includes a genetic etiology, some congenital causes, some acquired that include intracranial problems, AVMs, arteriovenous malformations, cerebral aneurysms, cerebral infections or cysts or stroke, either infarct or hemorrhage, or brain tumors. Metabolic alterations of fluid or electrolyte disturbance, hypoxia, acidosis, drugs, heavy metal, and hepatic dysfunction all can produce seizures. And then post-traumatic head injury. And many of these will produce acute seizures, but not epilepsy, whereas these that we see, these intracranial events, all of these have the possibility of producing epilepsy. The cause is unknown. The cause of the epilepsy is unknown in at least a third of the patients. The epilepsy etiologies vary markedly due to age. Perinatal injury results in epilepsy onset early in life. Metabolic defects tend to lead to epilepsy through the early years, but up into late in the first decade. Congenital malformations can produce epilepsy early on, but also extend up through the first decade. Infections show up maximally in the first decade as well. Some of the genetic epilepsies also show up in that first decade, entering into the second decade. But trauma particularly starts to show up in a later age range, that is in the second and third decades, when people are much more active, people are riding in more dangerous settings. We'll see postnatal trauma, brain tumors. That first seizures often present as brain tumors when people are on their 30s and 40s. And if somebody shows up with epilepsy in the 50s, 60s, and 70s, vascular disease should be suspected, or tumors, and they should be worked up for those possible conditions. The epidemiology of seizures recognize that at least 10% of the population will have a single seizure during a lifetime. And of that 10%, a number, perhaps 20, will recur within a couple of years, perhaps 40% within 5 years, and up to 70% a little bit later. But about half of those with new onset seizures, that is, if 10% of the population have a seizure at one point in their life, about a half of those will go on to have another seizure somewhere in their lives. About 4 to 5% of the population will have epilepsy, that is 2 or more unprovoked seizures at some point in their lifetime. The prevalence of epilepsy is somewhere close to 1% of the population. And of that 1%, about 30% of them continue to have disabling seizures. That is, they're considered intractable, even on medication. Another 30% have occasional or rare seizures. And then about 30 or 40% are well controlled on medications. The age distribution is markedly skewed in that epilepsy is much more common in the very young and in the very old due to those etiologies we've identified. The seizure type is also interesting distribution, and that is partial seizures that is especially complex partial seizures, sometimes known as dyscognitive seizures, are by far the most common, and these most commonly involve the temporal lobe, and they're often the most refractory to treatment. The pathophysiology of epilepsy includes an imbalance of excitation and inhibition in the central nervous system. There's either too much excitation, not enough inhibition, or some combination of the two that leads to high rate of neuronal firing and the synchronization between neurons that often are firing at different times during those that become epileptiform tend to fire synchronously. Results in hyperexcitable neurons that have a tendency to produce seizures. Intracellular recording from such neurons in these epileptic foci show something known as a paroxysmal depolarization shift. In this setting, in these neurons, there's a very prominent activation of glutamate NMDA receptors that lead to abnormally high calcium entry into the neurons. Following that, there's an after hyperpolarization due to potassium efflux. This intracellular paroxysmal depolarization shift event in individual neurons occurs in associated neurons that are synaptically connected, and it corresponds to what we'll look at called the interictal epileptic spike seen in the scalp EEG that is an indication from the outside the brain, that is recording from the scalp, that there is some epileptiform process going on in the brain. Other aspects of the pathophysiology of epilepsy, and that is during a seizure, there is a dramatic increase in ATP. There's a marked increase in cerebral oxygen consumption, a marked increase in cerebral blood flow, and a rapid increase in consumption. It's because neurons are firing at the highest rate that they ever do in life, and they need more energy, they need more blood flow, they need more glucose consumption. In those severe seizures, there is a lactate accumulation in the areas that are most involved. There's secondary hypoxia in those neurons that are most involved. There's acidosis in that region and consequential brain tissue injury. So repeated strong seizures have some tendency to damage the tissue that is engaged in this seizure. Why do seizures stop? Seizures engage neurons at the very highest level of metabolic and electrical activity they ever experience. In general, individual seizures are self-limiting, and they are stopped by the engagement of inhibitory processes, the very inhibitory processes that are mostly GABAergic processes, rather than exhaustion, although energy is maybe depleted in the area. However, redistribution of the ionic pools and metabolic substrate deficiency may contribute to the decreased electrical activity that we see following a seizure, where you often see flattening out of the EEG, and you also see Todd's paralysis, indicating dysfunction of the tissue that's been most involved. It's either actively inhibited or it's literally exhausted of its energy supply at the end of a seizure. The diagnosis of epilepsy is remarkable in that a good deal of it can be made by the history. Because seizures for a given individual are stereotyped, a given individual who has movement of the arm, a clonic movement of the arm at the beginning of the seizure, will have that clonic movement of the arm at the beginning of each seizure. If the person has a flashing light in front of their eyes at the beginning of their seizure, that will be the beginning of each of their seizures. So that's stereotyped behavior, and they would recognize it as abnormal, or you might recognize it as abnormal. That history will help to define that being likely an epileptic seizure. Seizures are paroxysmal, that is, they come on abruptly, they're highly stereotyped, and they're abnormal behavior that's suggestive of epilepsy. The diagnosis, as we said, is based on 2 or more such unprovoked seizures. The physical exam may be relatively normal or perfectly normal. in the individual in between seizures. The neurological exam may be perfectly normal in between seizures. But the EEG in such a person who has had a couple of unusual events, the EEG, if it has certain abnormalities, it would very strongly suggest that in fact that is the diagnosis and that is of epilepsy, and we'll see some examples of that. A CT of the head, that is computerized tomography, or an MRI of the brain are also very useful, not so much in making the diagnosis, but in helping to identify the cause of the epilepsy. Is there a tumor? Is there a cerebrovascular disease, a stroke, or a hemorrhage? Is there hippocampal sclerosis, that is loss of hippocampal tissue, which is a rather common feature in temporal lobe epilepsy? Is there a congenital malformation of brain tissue? Has there been head trauma or infection or a variety of other causes that might be picked up by the MRI or CT? And for at least a third of the patients, you'll never find, we have not yet found causes. It might also be helpful to get video EEG monitoring where you document the epileptic seizures in the hospital, where you're literally looking at the behavior as well as EEG at the same time to correlate those two to confirm that they are epileptic seizures. And you might also get metabolic studies, PET scans or SPECT scans to identify alterations in metabolism, and some advanced techniques that also recognize altered metabolism or magnetoencephalogram to help to localize abnormal electromagnetic activity. But a great deal of weight is placed on the history and the EEG in making the diagnosis, with the CT and MRI to help identify the cause of the epilepsy. In using the EEG, we see here a sample of EEG, and in this EEG we see each wave is coming from a different location in the brain, and we see these electrodes that happen to be recordings that happen to be coming from the left frontotemporal region have these events. These are interictal, that is between a seizure, epileptic spikes. They're sharp so that if you sat on them they might hurt. And you see them here in the frontal area and you see them here in the nearby temporal area. And that's an indication of very high frequency discharge in a selective population on the left side of the brain in the frontal temporal area. And that would be supportive of a person who has some abnormal movements, perhaps of the face on the right side, and they had epileptic spikes in the frontal area on the left side, or they had something that was going on in the temporal behaviors that were suggestive of temporal lobe, in which case we might see this activity in the temporal lobe. So it would suggest an abnormality in the frontal or temporal regions on the left, and it would support the diagnosis of epilepsy. But you can also sometimes record seizures during the EEG, using EEG. And if it were generalized, you might see patterns that are consistent with a 3 per second spike in slow wave or a bilateral polyspike in slow wave. We'll see some examples of the E during some of these. Or you may see focal seizures that suggest a simple partial seizure or regions that might suggest a complex partial, and recognize that a focal seizure may progress into a secondary generalized seizure when it spreads to the other hemisphere. We see here the EEG seizure onset during a generalized 3 per second spike and wave. And as you can see, over all of the various electrodes that are all located over different locations over the head, all of those sites became activated over both hemispheres at about the same time. And that's consistent with a primary generalized epilepsy. And this frequency of 3 per second, each of these major lines is 1 second apart. You see 3 of these spikes and waves. That is pathognomonic of absence, childhood absence epilepsy. And there are behaviors that come associated with that, such as a loss of consciousness and generally staring at that time. Here we see, coming out of a relatively quiet background, all of a sudden, over the entire brain, we see very rapid activity, and it occurs everywhere at the same time, and there's some muscle superimposed, and you see this regular rhythm. This is an alpha rhythm sitting back here. All of that is obliterated, and you have this low voltage fast activity, and this is all ongoing epileptic activity over the entire brain, both hemispheres at the same time, and it's consistent with a generalized tonic-clonic seizure. Here we see the EEG seizure onset during a focal seizure, a partial seizure. So you see, starting over here, you have relatively normal activity, and then at this point in time, right at this arrow, you start to see rhythmic activity at this location. This is all over the right temporal region, and you see it's rhythmic, it builds up, and it's consistent with an onset of a seizure, and this would indicate clearly when there's a behavior occurring that's abnormal during this time, that seizure originates in the right temporal region, anterior temporal region. On the other hand, here we see a patient who has an EEG coming out of normal activity. At this time, we see the onset of a sharp event right here, and then rhythmic activity. This rhythmic activity is occurring in the left frontal temporal region, and it's rhythmic, and it's particularly dramatic in the temporal region, and we'll see it building up over time. But in addition to building up in that region in amplitude, notice that we start to see the same rhythmic activity propagated over to here. This is over to the right temporal region. So it's spread from the left temporal area, continued in the left temporal area, went on into the right temporal area. And that bilateral activity is an indication of secondary generalization. At that point, the patient individual would be amnestic and would lose consciousness. We see here the use of the MRI and looking at a patient who has seizures. And this person has seizures that involve speech arrest, and the MRI shows a left temporal parietal tumor. We see it here in an axial section, and we see it also over here in parasagittal sections, and we see right up here in this parietal area, right here, there had been a small biopsy of identifying a tumor here, and even though the biopsy had taken place, the patient continued to have seizures, and the seizures involved speech arrest. So we knew that the seizures were coming from somewhere in the parietal and superior temporal area, consistent with near Wernicke's area. Not surprising that there was a speech arrest. If in that setting where you wanted to be able to see whether the seizures were coming from an area, how close they were coming from the tumor, this is a recording from implant brain mapping with intracranial electrodes, in which we're recording from electrodes around the brain tumor. The brain tumor is right here in this region, and we found that seizures were originating immediately in the tissue, just inferior and posterior. You're seeing the left hemisphere, occipital lobe here, frontal lobe here, parietal lobe here, and you're seeing the seizure is arising from this region. The individual had sensory cortex, and that sensory cortex over here had speech arrest in this region, indicating it's Broca's area, had slurred speech over in this area, suggesting it's motor mouth area. And we see that the seizure comes not from the tumor itself. Tumors don't generate seizure. The tissue next to the tumor is where a seizure may be generated, and that's what this would indicate to us. You can see here the seizure generated in that very tissue, sustaining and building in that parietal region. Here's another use of an MRI. In this case, a patient who had complex partial seizures and had right hippocampal sclerosis, that is atrophy of the hippocampus on the right, and that's a common finding in patients with complex partial seizures, that is atrophy or scarring of the hippocampus. The treatment of epilepsy involves most anti-epileptic drugs are GABA agonists. They enhance inhibition, or sodium channel blockers or calcium channel blockers that reduce excitation. The goal is to have no seizures with minimal side effects and improved quality of life. In order to select those, you identify the seizure type to identify the best anti-epileptic drug. And you're always considering the tolerability and long-term safety as features in selecting an anti-epileptic drug. And as we indicated, we expect about a third of the patients will become seizure-free, about a third will have rare seizures, and still, with our best treatment of anti-epileptic drugs, almost a third will be intractable, have continued strong seizures. Many anti-epileptic drugs are available with use guided by the type of seizure. Here is just one overview of some options available. I don't want you to memorize these, but recognize that it's introduced just to introduce some of the available anti-epileptic drugs. That is, all of these you see listed here are drugs that are available for use, and they tend to be distributed on those that are most useful for partial seizures, some that are more useful for generalized seizures, and some that are rather specific for ethosuximide, and some that can be used for both generalized or partial seizures. Don't take this as the gospel, simply as some of the types of seizures, and you might want to be able to choose. You may be able to choose medications that are preferentially beneficial to some types of seizures as opposed to others, and then guided by the use of side effects that are tolerable and the effective control of seizures. Other ways of treating seizures include non-pharmacological effects, and that is simply to remove the tissue that is generating the epileptic abnormality. Temporal lobectomy is among the most common of those. About half of the people who have surgical resections have a removal of a portion of the temporal lobe, especially the amygdala hippocampus, which can control seizures in many patients. But there are also a removal of other parts of the brain, such as frontal or parietal, and rarely a corpus callosotomy or removal of a hemispherectomy, particularly in very young children with intractable seizures. They manage to survive even a hemispherectomy. Vagal nerve stimulation or deep brain stimulation may also control seizures somewhat, and a diet, ketogenic diet and modified Atkins diet, may be helpful as well. Take-home points: seizures may be focal or generalized. The behavioral manifestations of focal seizures reflect the part of the brain involved. In some focal seizures, that is complex partial seizures, awareness is altered. And in generalized seizures, both hemispheres are involved and awareness or consciousness is lost. Each individual has a stereotyped kind of seizure. Each one will look quite similar to the other. But a different patient might have a very different type of seizure. The diagnosis based primarily on history, supplemented by EEG and MRI, so your history is very valuable. Epilepsy is a chronic disorder that may be treated with either anti-epileptic drugs, with diet, surgical resection of the epileptic tissue, or by electrical stimulation. Status epilepticus is life-threatening and must be treated immediately. A number of excellent online resources that you might want to take a look at that have both examples of seizures and very good brief discussions of seizures coming from Stanford. I recommend them highly. Thank you. If you have any questions, don't hesitate to contact me.